Hello, everyone. Welcome to the April 27th Opioid Abatement Authority Abatement Academy. First, my name is Jennifer Nelson. I'm Virginia Institute of Government Assistant Director for Membership and Engagement. The Virginia Institute of Government is the leadership development and community engagement arm of the Weldon Cooper Center for Public Service at the University of Virginia. Through our research, leadership development programs, and local government engagement initiatives, we continue to work towards our vision of good governance, equity, resilience in every Virginia community. VIG offers leadership development through SEI and LEAD, local government equity clinics, certification for treasurers and commissioners of the revenue, and customized training program. State agencies and local governments can access a range of consultation and support services to build more resilient organizations. We have a seasoned team of public sector leaders and subject matter experts ready and available to facilitate boards of supervisors, city and town councils, team strategic planning retreats, and other related events. Today, VIG is glad to partner with the Opioid Abatement Authority for the first of the Abatement Academy series, presented every second and fourth Thursday through 2023. A few housekeeping notes. This session will be recorded and posted on the Weldon Cooper Center for Public Service YouTube channel soon. If you have any questions, please type them in the chat and I will ask them for you at the end of the program. Thanks again for taking the time to join us today for this first Abatement Academy session. Now I'm happy to turn things over to the authority's Director of Finance, Adam Rosatelli. Adam?
Thanks, Jennifer. So hello and welcome again to the first Abatement Academy webinar. Again, the first of a series of free bi-weekly webinars launched by the Virginia Opioid Abatement Authority and the Virginia Institute of Government, the purpose of which is to highlight examples of programs that align with nationally recognized principles for the use of funds from opioid litigation. So again, my name is Adam Rosatelli. I'm the Director of Finance for the Opioid Abatement Authority. For those of you in attendance who aren't already aware, the Opioid Abatement Authority is an independent body, the purpose of which is to abate and remediate the opioid epidemic in the Commonwealth through financial support from the Opioid Abatement Fund for efforts to treat, prevent, and reduce opioid use disorder and the misuse of opioids in the Commonwealth. So for this inaugural Abatement Academy webinar, we are very fortunate to have Ms. Ginny Lovitt here with us today. So Ginny is Executive Director of the Chris Atwood Foundation, a nonprofit organization she co-founded in memory of her little brother, Chris, after he passed away from a heroin overdose at the age of 21. Trained as a family recovery coach and certified by the Virginia Department of Behavioral Health as a Master Revive trainer, she has 15 years of professional and personal experience with substance use disorder, launching innovative, low-barrier, evidence-based programming to save lives and support recovery. Ginny is also an award-winning advocate, having spearheaded the passage of several state laws that authorize community dispensing of naloxone and increase access to other life-saving services. She's particularly passionate about defeating the many stigmas surrounding substance use disorder and building bridges to create stronger systems of care. She has shared the message of support, not stigma, with outlets such as A&E, NBC, NPR, the Washington Post, and at the White House. So with that, I'm thrilled to allow Ginny to share her thoughts and experiences with all of us.
Hello, everyone. Thank you so much, Adam. And it's so great to see all of these folks here today from a wide range of areas in Virginia. So I'm pleased to see that. I'm going to go ahead and share my slides here. So first of all, I did just want to thank Tony and Adam and the other amazing folks at the OAA for inviting me to share here today, and for the really wonderful and hard work that they are doing to help people with substance use disorder. So I just want to say that this may not be sort of your typical educational webinar where somebody with 3 master's degrees shares 40 slides with charts and graphs and peer-reviewed data, although I am going to share evidence-based best practices with you. My primary purpose here today is really to do some storytelling. And I felt that to kick off this Abatement Academy, you're going to learn so much about the how, and I'll share some of the how too, but I think it's important to lead with the why, the mission, the need, the real people behind all of the devastating statistics that we're seeing. So this is a very personal battle for me. Just 10 years ago, I lost my little brother, Christopher, to a heroin overdose at the age of 21. And he had struggled with recovery for 6 years. He was in and out of treatment, in and out of recovery. And he slipped through some pretty gaping holes in the system of care for people with addiction, despite having the full resources and support of his family. And that's why we launched the Chris Atwood Foundation. That's why I'm here today and why I do everything I do. And I just wanted to share with you some of the experiences that Christopher and my family had. And then what I'm going to do after that is talk about some of the ways that we can work together to fill some of those gaps and make sure that this does not keep happening to future generations. So it is important, I think, to know that Christopher was just 15 years old when he became addicted to heroin. He's about 15 in this picture. We went on a zip lining tour in Alaska. But unfortunately, because he was so young when he got addicted, his brain really developed and formed around opioids at the center. He wanted so badly to be free of it. But addiction is really tricky because, some say it's a disease, and there's a lot of support for that. Other people actually think that it's more like a learning disorder. But either way, what happens with addiction is that the addicted brain sort of erroneously learns that the drug that it's addicted to is necessary for survival. So there's a part of the midbrain where our survival instincts live. And when someone sort of crosses over from maybe experimenting or misusing substances into full-on clinical substance use disorder, the drug or the alcohol or the behavior gets inserted into that list of survival needs. So it's kind of hard to describe to somebody who's never experienced it, but just imagine that if I told you that tomorrow, the consumption of all food was going to be made completely illegal globally, which of course I know is ridiculous and would never happen, but just imagine for a second what that would be like. You might try for a little while to be a law-abiding citizen and not eat, but your body is going to start burning for it. And every cell in you is going to be telling you that you need food. So how long could willpower override that biology? Because those instincts are so strong. They're one of the most powerful functions in our brain, and they're very, very hard to override, particularly if, like my brother, you're very young when those systems get hijacked. So I wanted to talk to you about some of the ways that as a struggling family, we were told to get help, and then, share with you our experience with doing those things to give you a picture of what seeking help can really look like. So the first thing that most people tell you, of course, when you're trying to get help for somebody is get the person into treatment, right? So people really want to believe, and, of course, insurance companies will tell you that a 28-day program is what people need. My family sent Christopher to treatment 6 times in the 6 years that he struggled. And this includes some of the best treatment centers in the country. They cost some of them $1,000 a day. And this was in a time when insurance didn't really cover treatment very well. So this was partially out of pocket. And I complain about that because we spent so much money, but we were also incredibly privileged to be able to do that. And many people aren't. But despite that, none of those 30 or sometimes 60-day treatment programs did many of the evidence-based things that we see a little bit more of now, but unfortunately still not common enough, which are the evidence-based best practices like buprenorphine, aka Suboxone, or none of them told us about naloxone, much less gave us access to it. So can you imagine sending your child to a state-of-the-art, top-of-the-line, $1,000 a day allergy clinic and they don't make sure that you have an EpiPen? So each time, what happened in these short stays in treatment is he would leave without a whole lot of therapeutic benefit to his brain, but what he would leave with is zero tolerance for the opioids that he had been using. So, that is a recipe for disaster. And, what he did have were huge cravings still, which always overcame him, and he would then start using again, and then was kind of, back where he started. And now experts in opioid use disorder and the brain say that a year of treatment is when the recovery rates and the prognosis starts to really improve for opioid use disorder specifically. But only 11% of people get treatment at all. And I don't have actual figures on this, but I would bet that far fewer are actually getting a year of treatment. So for us anyway, treatment wasn't working. The gold standard for treating people with opioid use disorder is buprenorphine. It reduces all-cause mortality rates by 50%, which is in the realm of medications, that makes it a very, very effective one. But it doesn't just reduce overdose rates, by the way. It's all cause. So that means deaths from car accidents, heart disease, everything else reduces your odds of death by 50%. But there's a myth out there that using these medications is just replacing one addiction for another. I'm sure many of you guys have heard that before, maybe even believe it. But that's really because a lot of people don't initially understand the distinction between addiction and dependence. So if you're diabetic, for instance, you are not addicted to your insulin, but you are dependent on it to stay healthy. Addiction is when all of the chaos comes with it, with dependence. So the life-wrecking side effects of addiction, and all the dangers and risks. But when taken as prescribed, Suboxone, buprenorphine, methadone, people are on them are leading normal, happy, productive lives. They're working, they're taking their kids to school, they're getting their lives back. So that was our experience actually with Christopher. When he was about 19, a psychiatrist did finally get him onto Suboxone, and he really stabilized significantly. For almost 2 years, he went from, absolute chaos, disappearing all the time, going to juvenile detention, to suddenly he's going to college. He's putting together, he's thinking about the future. And I was getting my brother back, and we were all so ecstatic. But unfortunately, what he experienced was a significant stigma. Many people told him in his support group meetings and elsewhere, that he was using a crutch. He wasn't in real recovery. He wasn't truly clean. So he felt pressured and got off of it before he was ready. He quickly then realized that the cravings that he was experiencing were way too powerful for him to manage, and that he needed to get back on the Suboxone. But on that fateful day, his psychiatrist just happened to be out of town. So he was calling and not able to reach her to get back on his Suboxone. And there was really no rapid access to buprenorphine. There still isn't. And he was starting to get sick. He had no money. The withdrawals and the panic were peaking, and in a state of desperate misery, he stole something to get money for heroin, and he started using again. So another solution, people are told to go to the hospital, right? If you have a life-threatening situation that's going on, where do you go? You go to the hospital. So after this recurrence of use that I just mentioned, he actually overdosed, which is not surprising. And then he was taken to the hospital. And, you know, most people at this point will think, well, surely in this medical setting in the hospital, he's going to receive the help he needs to get back on track. Addiction is a disease. Hospital, you know, they deal with diseases, right? But sitting by his hospital bed, you know, I asked them, what could we do? Because we tried so many things and nothing was working. And they just said, you know, to get him into treatment, but they didn't offer any referrals. They didn't, you know, give us ideas for where to go. There was no take-home naloxone, despite the very, very high risk of him overdosing again within days of being released. There were no peer support specialists or even social workers, no one to get him back onto the Suboxone that he had been doing so well on. No follow-up care, nothing. He was just Narcaned and sent home. And unfortunately, this is such a common occurrence that there's a term for it. It's called treated and streeted. So the hospital didn't help us. What's another common way that people are told to deal with an addicted loved one? My family heard this one all the time. Lock them up, throw them in jail. That'll teach them a lesson. It'll scare them straight, right? But the clinical definition of addiction is continued use despite negative consequences. So, you know, if the definition of this condition is that negative consequences don't really work, why do we keep trying them? Because if they did, we wouldn't be here as a nation, would we? So shortly after Christopher's overdose, I came out of my front door one morning and saw a group of police officers descending on the house, running towards me with their guns drawn. And they blew past me. They dragged him away in cuffs in front of me, and he was taken to jail because his prints had come up in the car where he'd broken into when he relapsed. And you know, in jail, like everywhere else, you know, he received no resources, no counseling, no peer support specialists. People leaving jail are 129 times more likely to die of an overdose in the days after leaving jail than the general population. So this is a critical transition point where people need to, at the very least, be getting access to naloxone, but he did not get that. And then he was charged with a felony, which meant that the whole last 2 years that he'd stabilized and worked so hard to get his degree were down the drain. And he knew that he was never going to be able to work in his chosen field with a felony on his record. And he was utterly crushed. And it was shortly after that I came home from work one day and I found him in his room unresponsive. And I did not have naloxone to administer it to him. And he died on February 23rd, 2013 at the age of 21, and my life changed forever. But Christopher was so much more than his disease. He was strong, smart, and had the most beautiful soul. He was immensely lovable and kind, but in the eyes of many, he was reduced to an quote-unquote addict. He was a young boy caught up in something so much bigger and more powerful than him. And he tried to get help so many times in so many places, but he was set up to fail and then punished for failing. He spent 6 years giving the fight everything that he could and being failed every step along the way, but being told that he was the failure. So if a 21-year-old kid goes through 6 rounds of expensive treatment, jail, and the hospital, and they still don't have the resources that they need to survive, then I will quote the former U.S. Surgeon General Jerome Adams in saying that this is not an individual failure, this is a system failure. We must do better. So there are many reasons, I think, why the system isn't better, but the big one, the big killer in my estimation, that is more deadly than fentanyl itself, is stigma. And it's everywhere, at home, in church, in jail, in school. at work, and yes, even in hospitals and other healthcare settings. Everywhere people with substance use disorder go, they're met with disdain and fear and judgment and rejection. And how long can somebody constantly experience that negativity before they start to believe that they really are worthless? So, that is really just a fraction of my family's story. And unfortunately, even though that was 10 years ago, the truth is that now, a decade later, if you're struggling and you're taken to a jail or a hospital or a treatment center, you're going to experience something very similar to what we did. And if you need Suboxone urgently to avoid a disastrous relapse, good luck. In the 10 years since my brother died, over 700,000 Americans have died from drug overdoses, yet very little has changed. But many of you here have the power and the positions and the connections to change that. My family, we didn't have any positions of power or leadership, but we did have the desire and the willingness to stick our necks out and demand change. And within just a few days of my brother passing, our family decided to start the Chris Atwood Foundation to try to fill some of those gaps in care so that our friends and family and neighbors didn't keep falling into them the same way that Christopher did. So now I want to take some time to talk to you about the solutions that we've come up with to fill some of these gaps, as well as talk about some of the barriers that we've encountered and overcome in order to implement those programs and to create a seamless, or we are continually trying to make it a seamless continuum of care that we call Revive to Thrive. And again, I mentioned already, one of the most important things to talk about is stigma. And there's so much that I could say about stigma. But one of the easiest things that we can all do to begin to reduce the damage that it causes is to use the right language. And at the Chris Atwood Foundation, we use person-first language. And I know it's hard to change how you talk about something. When you're so used to hearing certain terms, we've been sort of programmed for so many years to talk about things in a certain way. And, we're kind of just products of our environment. But, and I think a lot of people kind of feel like, well, they're just words. It's not that big of a deal. And, maybe people need to grow a tougher skin and not be so easily offended. And I myself, didn't really lend that much credence to the importance of language at first either. But if you identify with that, some research out of Harvard might actually make you feel a little differently. Because Dr. John Kelly there did a study where he took a bunch of nurses and doctors and therapists who were, of course, all trained in behavioral health and asked them to give recommendations for how to handle a particular case. And there was 2 case files. One, they were completely identical. It was a patient who had recently experienced a recurrence of use, but same demographics, everything was the same except for that, except for the fact that in one file, the person was described as an addict. And in the other file, they were described as a person with substance use disorder. So the group of healthcare providers who got the file with the person labeled as an addict were shown to be significantly more likely to recommend a punitive course of action for the patient. And these are highly trained clinicians. So, imagine how that might fare if we did the same study with the general population. So it's clear, and you don't need a study from Harvard to tell you, just ask somebody who's got substance use disorder. Words matter. And, we don't talk about any other disease this way, right? Do we? When my grandma had cancer, I didn't call her a cancer. I said she had cancer. So person-first language is really important, as well as many of the other terms that you see on here. I'm happy to send this slide out if anybody wants it, by the way. And so, moving forward with some of the ways that the Chris Atwood Foundation is addressing the gaps in care that my family slipped through. One of the first things that we had to confront was the legal barriers to getting naloxone out to the people who really needed it. Because even though we were willing to pay for it and get it out there, the existing laws in Virginia at the time prevented us from doing that. So we got the law changed. And then, dispensing nasal Narcan at $75 a box was too expensive. So we got it amended again to allow us to dispense the vial and syringe method of naloxone, which increased our dispensing power 100-fold. But then the next barrier was that there was too much administrative red tape to, keeping people from being able to become trainers and then dispense the Narcan. So we had to get the law amended again. By the way, Virginia and Ohio are the only states in the country that classify naloxone as a controlled substance, which is bizarre. But still there wasn't widespread access in many parts of the state. And so we launched a statewide mailing program, which has now reached 130 of the 133 different cities and counties in Virginia. And we're going to share with you a link where you can check out that page of our website. So we have now distributed over 110. This slide is actually, the numbers are out of date now. We've given out over 110,000 doses of naloxone. We've received reports of over 1,800 people who have been revived from overdose using that naloxone. We are also involved in recovery housing because transitions are such a critical point for people with OUD, with opioid use disorder. They are the riskiest period for somebody in early recovery, especially if they're leaving incarceration or those short abstinence-based treatment facilities, and they're leaving with no tolerance. So we provide short-term recovery housing grants to help people transition more seamlessly into the next step, into safe and drug-free living environments. So we've been able to provide $500,000 in grants over the last 7 years to help 1,700 people to forge a more successful path to recovery. Because without a stable, substance-free place to live, it is nearly impossible for anybody to maintain recovery. Despite all of our hard work with naloxone access, though, death numbers were still catastrophic. Synthetic opioids like fentanyl were causing widespread loss. And, we knew that many people in active use, we were not effectively reaching. They were dying of overdoses, getting hepatitis C and HIV, and there were really no services designed specifically for them to stop these preventable issues. So we kept researching and asking our community members, asking other organizations, what do we do? How do we reach these people? And we kept getting pointed back to harm reduction. And it turns out, we'd been practicing that for a while with Narcan, but didn't know it. But we needed to do more. And syringe service programs are supported by many different organizations, including NIDA, the CDC, SAMHSA. And evidence shows that participants in a syringe service program, or as they are known in Virginia, which I actually like this term better, it's comprehensive harm reduction programs, because we do a lot more than just give out syringes. But people who are engaged in a comprehensive harm reduction program are 5 times more likely to get into treatment than somebody who's using drugs who's not in one. And areas with those programs see a 50% reduction community-wide in the spread of bloodborne diseases. So they're keeping people alive and they're protecting the entire community. But despite the overwhelming body of long-ranging positive data supporting these programs, there was only 3 in the state at the time, and they were all, had low enrollment. So we tried in 2018 to start a syringe service program, but the law said that we had to get police and local government to approve the program. And so then we sat in 2 years of meetings trying to make that happen. And the folks in our area, we're based in Fairfax County, we're not opposed to it. They were just slow and bureaucratic about it. And I knew that, well, if it's taking us 2 years to get nowhere in Northern Virginia, then and some of the other places, there's just no chance we're going to get the sheriff or the police to sign off on this. So we had to go and get the law changed again to remove that requirement, and instead police and local government are notified that a program is coming, and they're consulted. They're given the details and the security plans and all of that, but they don't have to sign off on it. So our comprehensive harm reduction program has been in operation for a little over a year and a half. We now have over 600 members. And from our Narcan van, as we call it, and you can see it in the background of this photo, our motto is no judgment, just love. And our peer support specialists, who are some of them are pictured here, run the program. And, in addition to sterile use supplies and safe disposal, they provide a listening ear. They provide authenticity and relatability, which is something that only they can do. They help with making medical appointments, with basic sanitary supplies and feminine care supplies, disease testing, and of course, help people access treatment. And we have had the great satisfaction of being able to see a lot of our participants get the help that they need and pursue recovery. Like one of them, Sonia, who helped us we helped get her into treatment. She came to Dan, who's the peer on the far right there, and she'd been coming to the program for a couple months, and she said she really wanted to be able to be allowed to attend her daughter's wedding, but she had to get healthy first and stop using fentanyl. We were able to help her with the resources. She got into a detox and then a treatment program, and she was able to attend her daughter's wedding. And now she comes back periodically to just say hi and to actually help us and volunteer for the program. And we have found a really great partner, by the way, with the Fairfax County Health Department in this program. They're very supportive, and they actually provide our syringe disposal for us. So we take the syringes back and then they dispose of them, and that saves us a ton of money. They've also offered to help us with data evaluation. They came to us with a really great idea, which we're still noodling around with, to launch what's called a bad batch alert system. And that would combine two of our strengths, actually. With their team of data specialists and epidemiologists, they would be able to design an algorithm and a platform and monitor local EMS data to detect spikes in overdoses. And then with our trusted relationships and connection in the using community, we would then sign people up for these notifications for the bad batch alert, and we would let them know if there's a spike, especially if there's, specific information like avoid the green pills. So there are many different ways that private and public are better together. And that's just one of them. There's a lot of other ways that we work with local government. And another great example of that actually is our HOPE team. HOPE team, by the way, stands for Harm Reduction and Overdose Prevention with Lived Experience, which, if you were following that acronym, would technically be the HOPE team, but that doesn't sound as good. But the HOPE team is an innovative partnership between the Chris Atwood Foundation, the Fairfax County Community Services Board, and the Fairfax Sheriff's Department, through which magic happens. So what happens is people are taken to the Fairfax jail, and they're immediately screened for substance use disorder. And if they are interested, then they're promptly started on medication for opioid use disorder, typically Suboxone, but they're starting to offer the Sublocade injection as well. And then from there, they're immediately connected to one of our peer support specialists. We have an office in the jail now, and our peers, have actually, almost all of them on this program have been inmates in the Fairfax County Jail themselves. So they make that instant connection with people that it might take another behavioral health worker weeks and weeks to develop. And you can really see the change in people's faces, by the way, when they realize they're talking to somebody who truly gets it. It's nothing short of magic. And then, our peer gets to work making plans for meeting the needs of their clients, broad range of different things, of course, recovery coaching and planning, but also things like getting birth certificates and other documentation. And they work on employment readiness and applying, starting the housing application process. And we get one of our housing grants lined up for them. And then we arrange transportation. So when they get out, they're taken by our Uber Health service directly to their recovery residence. Whatever they need to get and stay healthy, we try to make it happen. And the CSB, the Community Services Board, they do a lot of those things as well, but they're only tied to Fairfax County. And so because we're independent out in the community, we have funding from a variety of different areas besides Fairfax. Our peer support specialists can stay with people across county lines and can work with people without those interruptions in care that so often cause major problems for people. But this program has not been without challenges. We did not stand it up overnight. When we launched the HOPE team, so many of the rules were working against us. Some of the folks in the jail just flat out refused to get on board with the idea of helping and medicating people with substance use disorder instead of, punishing them and just letting them sweat it out. So they were let go. The medical folks had to take special trainings and totally rewrite their protocols for medication management so that they could start people on Suboxone. And there were concerns and meetings about diversion, but they worked through them because, as Sheriff Stacey Kincaid always says, we need to get to yes. This is what's going to save lives. This is what's happening. Because the Constitution gives people who are incarcerated the right to medical care. And the folks there realized that medication for opioid use disorder is the most effective treatment for opioid addiction. And so the sheriff wouldn't stop until we got to yes. And we started saying that now too. When lives are on the line, we have to keep going until we get to yes. So, when they launched the program, the jail staff that had the initial misgivings about everything were convinced virtually overnight. They said that the difference in the health and well-being and the attitudes of the people incarcerated was night and day. And they are now all 110% supportive of providing medications for opioid use disorder in the jails. And the Chris Atwood Foundation, actually, they asked us to start an MOUD support group for people on Suboxone in the jail. And our peer supports do that, peer support specialists do that, and help to address some of the antiquated stigma that people on those medications face. And another issue that we dealt with was that people with drug charges weren't allowed to provide services into the jail. But most of our peers have drug charges on their record, and that's part of what makes them so relatable and effective at meeting people where they are. But we worked things out, and now our team of, as they would say, I only use this word for effect because they use it, but our team of ex-cons now have security badges to walk freely in and out of the jail as they wish. And this in and of itself, by the way, caused a big sort of culture shift in the jail where the value of peers was really fully grasped. And despite all of our hard work, though, we and still do in many cases, but we did find that, we lose touch with people sometimes when they get released. And after tracking down some of the folks and asking them some questions, we found out a lot of times it's for simple reasons, like they didn't have phones when they got out. So we started buying phones, prepaid track phones with 3 months of service, and then preloading them with our resources, our contact information and local resources. And then we had to make sure that we could get it into their personal property so that they had it when they got out. So we had to work all of those things out. But now people who are leaving jail, who are part of this program, they're walking out with a backpack that contains Narcan and a phone with all the resources and contact information they need, and a kit that has some personal hygiene supplies and protein bars, and a ride to their recovery house. And this really innovative program, by the way, shameless plug, is getting recognized nationally. New York Times bestselling author Beth Macy, she's the author of Dope Sick, which was recently made into a Hulu series. She wrote a new book called Raising Lazarus, and in it she praises this program as a model for jails around the country. And we do hope that people listen to her. And Sheriff Kincaid is always happy to talk to other law enforcement about how she made that work. But so getting back to my brother, you know, I told you about his story, but now I want to share with you a contrasting story from a member of our Revive to Thrive continuum of care. His name is Joseph. And Joseph was in active use. He was part of our comprehensive harm reduction program. And after a few months, he asked for help getting into treatment. So we did that, got him into residential treatment. And then the peer kept working with him while he was in treatment and when he got out. And when he was getting ready to leave treatment, we got him set up with a recovery housing grant. When he left, we used our Uber Health account to get him straight to his recovery home. At the home, he was given our Narcan. We equip all the recovery homes in the area with Narcan. And he actually later, as is very common, experienced a recurrence of substance use disorder, which, by the way, the rates of recurrence of use of, you know, quote unquote relapse with substance use disorder mirror the rates of recurrence of symptoms for many other diseases like hypertension. So they're really the same. It's very common. It's just that addiction carries a stigma with it. But he was able to take that Narcan with him when he relapsed, and that Narcan actually saved his life when he overdosed a couple of weeks later. Shortly after that, he re-engaged with his peer support specialist, got back into treatment again and back into housing. And then this time he did really well. And after continuing to work with this peer support specialist for a number of months, he then enrolled in and has recently graduated from our Recovery Academy, where we train new peer support specialists. So now he is ready and able to pursue a meaningful career in the field of helping others get through what he went through. And that is just one of the many stories of the power of a fully resourced continuum of care, where the hard work is put in to make it work and to get to yes and to fill those gaps and smooth over the transitions. And it's not easy, and it takes time and it takes funding, but God, is it worth it? And it's not easy, like I said, but instead of taking no for an answer and letting our community members keep dying all around us, what we did was we got together public and private partners, people we served included, and we said, how do we make this work? And we have to keep asking ourselves that over and over again, but each time we overcome one of these barriers, we get closer and closer to creating a truly seamless continuum of care where people don't have to die because there is a resource for them and a person to hold their hand every step of the way. And none of this, of course, would be possible without the financial and technical support and partnerships from our local and state government partners, the Community Services Board, the Sheriff's Department, the Department of Health, the local and state departments of health, the Department of Behavioral Health and Developmental Services. They have all funded and helped us in various ways to grow into what we are today. And our next steps are to create a similar system of care in hospitals that we have in jail, which I know seems super backwards to model a hospital program after a jail program, but that is the effect that stigma will have, and that's a goal of ours. And we are funded to do what we do because we are created and operated by people with lived experience. Because we have that, that authenticity and relatability with the people that we serve. And because we are a smaller private organization and we're more nimble to stand up programs quicker and more innovative to try new things that maybe government is worried about getting too much public scrutiny for, we're quicker to change and respond to needs with more agility. We get things done because of that, but because it's our friends that are out there dying. It's our family, our loved ones. And most importantly, we are able to reach a specific population of people who are not willing or able to engage in care anywhere else. People in recovery from substance use disorder, our peer support specialists are some of the most driven and resourceful people that you will ever meet, and seeing them be able to turn their pain into saving lives is just incredible. So this is some of our team, and I really cannot overstate the value of authentic peer-led community groups. These organizations, and we're not the only one in Virginia, are the most determined and scrappy people you will ever meet. And maybe you haven't heard of some of them in your area because they don't have the funding and support that we've been fortunate enough to have to grow. Their founders, in many cases, I know, are still out there using their own minimum wage paychecks to fund their programs, and delivering food and hugs and Narcan behind dumpsters and going into trap houses to give HIV tests. But the flow of these new funds from the opioid settlements that will be channeled should make it possible for more peer-run organizations like ours to expand and to do what we do best, which is just doing whatever it takes to save lives. And I really want to stress that, people with lived experience have fought hard for their recovery, and their experiences are worth their weight in gold and worth funding. Their credibility, their drive, relatability, and ability to connect with struggling people is absolutely unmatched. And I truly hope that the Opioid Abatement Fund can foster this precious resource. And I recognize that in order to create meaningful public-private partnerships to spend this money, we're going to have a certain degree of compromise, or getting out of our comfort zones, because these smaller peer-led organizations might be a little more rough around the edges. They're not used to filling out time sheets and expense reports. Maybe their staff swear a lot and have tattoos, and the only suit they own is the one that they wore to court. But they know how to save the world with a $5 bill, and they know how to change somebody's life standing outside of a 7-Eleven at midnight. And we need more of that. These groups are flexible and adaptable. And on the flip side, I've talked to many folks in more bureaucratic government organizations who are sort of bogged down with the reports and systems and procedures, and lament that they spend so much time with the red tape that sometimes they don't feel like they're getting things done, but they have resources, connections, in many cases funding, and the authority that the grassroots organizations don't. By contrast, they are strong and steady. But if there is one thing that I want to leave you here with, it's that making true progress in the opioid crisis is going to require us all to accept change, do things differently, and get uncomfortable and roll our sleeves up. It's now is not the time to hope that decades-old systems that have never worked before suddenly start working now. They're not. Now is the time to make new systems, to adapt and be flexible. Similar to a skyscraper. If you build a tall building, totally strong but totally rigid, it's going to be brittle, and a gust of wind is going to knock it flat. But if you build it with both that strength and flexibility, then it's going to weather the storm. So making progress in this epidemic it's going to take everything we've got, all hands on deck. And I want to see this money bring everybody to the table, particularly the folks with lived experience, in a way that works for everybody. And the grassroots organizations might need to find ways to adapt to the bigger funders, systems, and government funders might need to find ways to reduce some of the administrative burdens on community-based organizations, and be willing to try new things and create systems change. But if we are willing to get out of our comfort zone a little bit, if we do this right, public-private partnerships can be the potent antidote that we need to stop the overdose epidemic. I truly believe that. So that's all I've got. Thank you so much. My contact information is on this slide here. And I think we can email that out as well, or drop it in the chat, but we do have some time for questions.
Thank you, Ginny. Thank you so much for sharing your story of the Chris Atwood Foundation and the reasoning behind it. I'm so glad that the Opioid Abatement Authority brought you in first to set the tone for their Abatement Academy. Thank you. Yes, I will be able to send the first person first language slide to everyone in a follow-up, as well as Ginny's contact information and a little bit more information on the Chris Atwood Foundation. Are there any questions? Go ahead and put them in the chat. Ginny, I think people are just still absorbing your powerful speech. So far,
so good. They're just dumbstruck.
So far, there's just appreciation. There are no questions.
Well, thank you. I appreciate the appreciation. And I don't know, I couldn't see when I was in presenter mode if anything was coming into the chat. Oh, you did share the Get Narcan.
Yeah.
Yeah. So the link to our Narcan mailing program is in the chat. That's just one simple way that everybody can provide low barrier life-saving resources to folks in the community.
And I will include that again in the follow-up email, which will include the link to the video of this session.
Awesome.
I do have a question that came in. How are you able to get more support from the local politicians and policymakers?
It's all about building relationships mostly. I think we have a strong team of folks in the sort of advocacy realm, and we do harm reduction, right? And that is something that some folks are not super comfortable with. And we've developed ways to meet people where they are. That's a tenet of harm reduction, is to meet people where they are. And that refers to the people that we serve, whether that's literally physically meeting people out in the community where they are, or just mentally meeting them where they are emotionally or on the spectrum of their addiction. That also refers to politicians, policymakers, other leaders. It's compromise, it's meeting people where they are, it's speaking their language, and just being willing to get to yes. And I think sometimes, especially when people are super passionate about something, they can come in and be a little bit abrasive about it. And we've just always taken the approach that you get more bees with honey, and let's figure out how to do things in a way that works for everybody, and understand that, like, this doesn't need to be a battle. There's so much polarization. We've always tried to meet people in the middle and be gap bridgers. And it's worked really well for us so far.
Thank you. Here's another question. Can you tell us more about your Recovery Academy and the latest legislation regarding barrier crimes as obstacles to peer recovery specialists?
Yes, so our Recovery Academy does a few different things. So it provides the CPRS training, the 72-hour training to become a peer support specialist. So we do that in-house. We can do it virtually and in person. And then from there, we have our Recovery Academy trainer will work with people on getting prepped for the test. So she's got a test prep course that she will do as well, because the test can be deceptively hard to get certified. And then after that, we take some of the best candidates and we offer them an internship. We offer 8 internships annually to get your 500 hours, because that's frequently a barrier for people, is getting those 500 hours. It's a paid internship. Oftentimes after the internship is over, we're also able to offer employment. And then the legislation regarding barrier crimes, this past legislative session, so I believe it's going into effect July 1, unless there was an emergency clause that I'm not remembering. It reduces some of the barriers to becoming a peer support specialist because, as I mentioned earlier, people with certain drug-related crimes, or, you know, if the crime was too recent, are not permitted to do certain things like get into jail or become certified as a peer support specialist or registered as a peer support specialist, which is what you have to do to be able to bill Medicaid. And we do have a higher reimbursement rate for peer support specialists now also. So that list of barrier crimes was amended and reduced so that it is easier now for people with lived experience with incarceration and the justice system to be able to become peers, because then they can actually use that experience for good. And it's pretty amazing. Recovery is purple. Yes, I agree. I love that.
Well, that wraps it up for questions. Oh, of course. Here we go. Do you have recommendations on recovery/transition homes in the Richmond area?
We have a list, a resource list. We don't operate in Richmond, but we do have a number of contacts there, and I can send out, if you just email me, I can send that.
And again, I'll be including Ginny's contact information in the follow-up email. It'll be a couple of days so that we can process the video, but it's coming. It's coming. Anyway, HB 1525 was passed in the most recent session of the General Assembly and reduces the barriers to employment. So there we go. Thank you, Tony. And thank you, Tony, and the rest of the Opioid Abatement Authority for hosting this Abatement Academy, which will be the 2nd and 4th Thursday through 2023. We'll have other great speakers that can provide best practices, just like Ginny has with us today. Thank you again, Ginny, for sharing all this information with us today. And thank you for the Opioid Abatement Authority for allowing us to bring this to you today. Thank you, everyone.
Thank you, and feel free, anyone can reach out to me afterwards if you have additional questions.
Thank you.